Hey everyone, here's another free video about one of those big topics that seems to be on everyone's minds leading up to their exam, diabetes. And so this video will quickly and briefly cover the ins and outs of diabetes, especially those with type 2 diabetes, as that is what we will see most commonly in primary care. And actually, 90 to 95% of diabetes patients are type 2 according to the American Diabetes Association. So let's get started on what we should know about diabetes as novice nurse practitioners. So here's the bulk of what we're all going to need to know about diabetes. The two types, diagnostic tests, treatments, definitely that metformin, we're going to focus on that pretty heavily, complications, and annual referrals. This video, like my other free video about lab work, will be a little bit more in depth than I usually go in the review course, and that's because the review course is a knowledge check, while these videos are supposed to give you a little bit more of that foundational knowledge base. However, I will still ask some questions throughout the PowerPoint so you can gauge where your knowledge base is today. Overall, I'm going to be able to break all these components down for you so you can build up your knowledge and ace your nurse practitioner exam. So the very first thing that we need to be able to decide as nurse practitioners is whether our patients have type 1 or type 2 diabetes. And this is actually pretty easy. And why is that? Well, we know that type 1 usually shows up much earlier in life and hardly ever after age 30. And typically it presents a little bit differently than type 2. So let's dig a little further and talk about the patho behind each type. Type 1 diabetes is where there's an autoimmune destruction of what? Those pancreatic beta cells. And so what does that autoimmune destruction mean for your patient? Well, eventually insulin production is going to cease altogether, right? So there's something I would like to stop right here and note. Once you lose your beta cells, there is no getting them back. And this really spells out disaster for our type 1 patients. Because if we now have no insulin in type 1 because we no longer have beta cells, right? What is our body going to use in its place? Fat. And what does that fat breakdown lead to? Ketone formation. And as those ketones build up and the patient's blood becomes more and more acidic, what will our type 1 patients be at a really high risk for? DKA. And actually a lot of children who are diagnosed with type 1 are diagnosed when they show up to the ER in full-blown DKA. So now let's talk about type 2. Type 2 is easier for us new nurse practitioners to remember because we see it so frequently in practice. I mean, some days it feels like every other patient that comes in has type 2 diabetes. So in type 2, have we lost all of our beta cells like we had in type 1? Typically, no, we haven't. And actually, there was a statistic that I saw that showed that patients usually at time of diagnosis of type 2 diabetes have lost 40 to 60% of their beta cells. And so we've got some wiggle room, right? It's not like type 1 where we don't have any beta cells left anymore. We've still got probably about half of our beta cells left when we're diagnosed. And so our goal here is going to be to stop the further destruction of more beta cells. We need to keep the cells we have, and we need to keep them secreting insulin for us, right? At this point, we're pretty much going to leave type 1 behind and focus solely on type 2. And what are the risk factors for type 2 diabetes? Well, as we can see on the slide, there's definitely a lot, including obesity, sedentary lifestyle, unhealthy eating habits, and so on. But is there a pattern to this group of risk factors? Well, for the most part, the majority of these are modifiable, right? And that's huge. It means we can help our patients mitigate their risk for diabetes and reduce their diabetes progression just by making healthy lifestyle changes. How wonderful would it be if all major illnesses were able to be modified and managed in the way that type 2 diabetes is? However, we all know that the hard part is actually getting our patients to work to modify these risk factors, right? And so our approach to diabetes as novice nurse practitioners should definitely be based in holistic care and motivational interviewing to establish the positive benefits of actively working to control the patient's diabetes. It is definitely a team effort. You and the patient have to be working together to control type 2 diabetes. So what are some of the signs and symptoms that would indicate our patient may be diabetic? Well, people always want to go straight to the 3 Ps. So the 3 Ps, polyuria, polydipsia, and polyphagia, aka the really fancy ways of just saying increased urination, increased thirst, and increased hunger. But we kind of all know those, right? That's like the basics of basics. So what else? What other symptoms might you see? What might we see on the back of their necks? How about agathosis nigricans? Definitely want to mention fatigue in there, as well as peripheral neuropathy, frequent infections, blurry vision, dizziness, irritability. Truly, the list for diabetes goes on and on. With it being so common, if you have any suspicion your patient has diabetes, especially in the presence of those risk factors that we've already talked about, let's go ahead and do some further investigation and be really thorough novice nurse practitioners. It's important that whenever we talk about diagnostic tests and screenings for diabetes, we mention that we can also screen for pre-diabetes. And this is wonderful because we can try to prevent them from ever having full-blown diabetes through positive health interventions and possibly some medications, right? And so what medication is typically used for pre-diabetes? That's definitely going to be metformin, right? And so when we talk about these diagnostics, we're going to talk about the pre-diabetes value and the actual diabetes value. So at what hemoglobin A1C level will we diagnose our patient with pre-diabetes? 5.7 to 6.4%. Anything 6.5 or greater is going to indicate actual diabetes in our patients. What fasting blood glucose would diagnose our patient with pre-diabetes? 100 to 125. Anything greater than 125 would be actual diabetes. What 2-hour oral glucose tolerance test result would diagnose our patient with pre-diabetes? Well, that would be a glucose between 140 to 199 if they originally had a normal fasting glucose. A 2-hour oral glucose tolerance test result greater than 200 indicates actual diabetes. What random plasma glucose level would indicate actual type 2 diabetes? And that's going to be a glucose greater than 200 with symptoms. Do not forget, there also have to be symptoms with this one in order to make a true diagnosis. Now, what about glucose in the urine? Is that an accurate measure for diagnosis of diabetes? No, it's not reliable enough and therefore cannot be used as a diagnostic. So type 1s don't have any beta cells, right? And so we already know that just because of that, they're going to be dependent on insulin the rest of their lives. Oral medications are not going to cut it for type 1s. But what about type 2? Do we have to jump right to insulin? Well, it really depends on the hemoglobin A1C. And so at what hemoglobin A1C would you need to initiate insulin right away? Well, I've really seen sources vary on this, but it looks like the overall consensus is greater than 9%. Like I've said before though, your exam will make it obvious for you when it wants to get a point across. It's not going to put things on the borderline. Generally though, we're going to be able to catch diabetes before we get to the point of insulin. And that leads us to our number one medication for both diabetics and pre-diabetics, which is metformin. In primary care, metformin is like the holy grail of diabetes medications. Why is that? Well, it's oral, so no injections, and it also has a very low side effect profile. And so let's dig a little deeper into metformin. So as I've said, we absolutely adore metformin. It is our go-to medication for type 2 diabetes. You are going to see this out the wazoo in primary care. So we really need to hit on everything. First question, does it cause hypoglycemia? No, which is part of why this drug is so great. Why doesn't it cause hypoglycemia? Do you remember the mechanism of action of metformin? It actually inhibits glucose production by the liver, and that's why there's no risk of hypoglycemia. Something else important to note here is, does it cause an increase in weight? No, it's weight neutral, and some people even lose weight while they're taking it. And that's yet another reason why metformin is such a great medication for those with type 2 diabetes. What about the max dose of metformin? It's right about 2,500 milligrams a day. And what is our typical starting dose going to be? 500 milligrams BID, and then we increase it as tolerated. What usually impedes our ability to increase the dose of metformin? That nasty GI side effect of diarrhea. That seems to be the #1 complaint of patients taking metformin. So now that we've talked about how wonderful metformin is, we also need to discuss some of our concerns with it. Who is it contraindicated in? Anyone who has a GFR less than 30 can absolutely not take metformin. You can use it in someone with a GFR between 30 and 46, but what are you going to have to do to the dose? Cut it in half. We also need to stop metformin for a short time leading up to any procedure with contrast dye. Why is that? Because of the possibility of lactic acidosis. And last but not least, what vitamin deficiency can metformin cause if used long term? B12. Extra question here, what female reproductive issue is metformin used for commonly? PCOS. And like we've already said before, I just want to reiterate one more time, we can use metformin for pre-diabetics. This is an absolutely wonderful drug. Now what about all those other diabetes medications? We just went over everything for metformin, but with these meds, we're going to do more of a flash round and pull out the highlights. So let's see what you know. I know I haven't listed every medication class here, but please remember, this exam is about knowing the basics and the overarching concepts. And so which of these drug classes puts us at the highest risk for hypoglycemia? Definitely those sulfonylureas like glipizide. What two major organs are we concerned about in those who are taking TZDs? The heart and the liver. This class can cause hepatotoxicity and cardiotoxicity, and it's a big no-no in those with heart failure. Those heart failure patients will gain weight on this drug, which is always what we're trying to avoid, right? Which two classes listed are known to be cardioprotective and decrease overall cardiovascular risk? That's going to be the SGLT2 inhibitors and also the GLP-1 agonists. Which of these drugs would we not want to prescribe to elderly patients with incontinence issues or in those who have frequent UTIs? That's definitely going to be the SGLT2 inhibitors. They make us pee out all that glucose, right? And so that can be a recipe for disaster with those two particular patient characteristics. Which of these drugs are an injection? That's going to be those GLP-1 agonists. And so if our patient says, no way, I'm not going to stick myself, then the GLP-1 agonists are not going to be our first choice. What medication class is contraindicated in those with a history of thyroid cancer or pancreatitis? That's going to be those GLP-1 agonists. And so an extra question here, a little unrelated, what is our preferred treatment for gestational diabetes? Do we use the oral medications? No, we don't. We actually only do insulin for those with gestational diabetes because insulin does not cross that placental barrier. So let's talk just a little bit extra about those sulfonylureas. These for a long time were add-on therapy to metformin. They were like a go-to to add on to metformin. However, We have so many medications now that it doesn't have to be our go-to anymore. But let's talk about it a little further, as the sulfonylureas can still be popular drugs as they are so cheap. Remember, the newer the med, the more expensive it is. Many of our patients with diabetes will be on multiple meds, and that cost adds up really, really quickly. And so which medications are the sulfonylureas? Do you know any of the names? They're the ones that end in "-ide". So glipizide, glyburide, those. Do they affect a patient's weight? Yes, they do, and they can actually lead to weight gain. So that's very important to remember. And what is the biggest common issue with someone who is taking a sulfonylurea? It's definitely that they cause hypoglycemia. So now you're asking yourself, I know metformin is first line, but where do I go from there? And yes, there are a lot of options, but don't panic. We love having options as novice nurse practitioners. We just need to look at our patients holistically and look at their individual characteristics. If they're elderly, maybe we want to avoid the sulfonylureas due to the hypoglycemia risk, right? Because if they're hypoglycemic, they're more likely to fall. If we have a patient with heart failure, then we know we don't want to use those TZDs. And so it just kind of goes like that. Overall, we just need to look at their age, weight, comorbidities, as well as the cost of the medications and the side effects of the medications. And so if you choose something that doesn't end up working for your patient, that's okay, because we have plenty of other medications to choose from, right? So now we obviously need to discuss insulin. And we're typically going to start with basal insulin. Can you think of any long-acting insulins we might use? Well, I always think in my head, long, Lantus, and Levemir all start with L, and it helps me keep it straight in my brain. And so we're usually going to start patients on these at night, and we love our long-acting insulins because they provide coverage for the whole entire day, right? 24 hours. How often will we have the patient titrate up their basal insulin if it's needed? It's usually 2 units every 2 to 3 days until we reach our goal. Then, once we have them on basal insulin, we can also put our patients on bolus insulin, also known as short-acting. And so these are insulins like Humalog, Novolog, etc. And we can also titrate up with our bolus insulin that will only be 1 to 2 units every 2 to 3 days. Remember, our bolus insulins act fast. We don't want to overdo it and bottom our patients out. And so they need to consistently be doing their blood glucose checks as prescribed as they're doing these titrations. I think as a whole, a lot of people really overthink insulin. I honestly could probably do a whole lecture just about insulin. But here's my recommendation for you as you study for your exam. Know your onset, your peak, and your duration. These are straight memorization, okay? If you're struggling, try making flashcards and refreshing it over and over until you have it. There's really no easy way out on knowing insulin. A general tip, though, is just to remember that we decide what type of insulin to increase by whether their postprandial or their fasting blood glucose levels are higher. If the postprandial readings are higher, then we increase their bolus insulin. If the fasting blood glucose readings are higher, then we increase their long-acting or their intermediate-acting insulin. Before we talk about complications, I just want to throw out there that we talk about Don versus Samoji in my review, so I'm not really going to hit on that here, but it's definitely something to keep in mind. Almost all of our diabetes complications fall into one of 2 main categories, microvascular or macrovascular. The microvascular complications are easy to remember because it's all the opathies: neuropathy, retinopathy, and nephropathy. The kidneys and the eyes are huge concerns of ours with diabetes. Remember to take a second look in the cotton wool spots, as they are a known ocular issue with diabetes that need to be referred right away. With macrovascular complications, we worry about those bigger vessels, So now we're thinking things like coronary artery disease, peripheral arterial disease, strokes, etc. And so what's the best way to prevent these complications for our diabetes patients? Well, it's to do regular screenings, right? And so let's talk a little further about the screenings that we should be doing. So annual referrals and screenings. Let's start with the eyes. So what are we worried about happening with our eyes? Definitely thinking about cotton wool spots, neovascularization, and microaneurysms. And not only are we worried about those issues, but we also worry about those long-term issues like cataracts and glaucoma, right? And for our diabetes patients, they should be seeing an ophthalmologist every year after they get diagnosed to get a dilated eye exam. They also need to be seeing a podiatrist every year. Every diabetic needs to be taught to meticulously care for their feet, because we know that people with uncontrolled diabetes or long-term diabetes end up with issues with restricted blood flow, right? And due to that restricted blood flow, we have issues with neuropathy. So if your diabetic patient can't feel their feet and then they get an injury to their foot, their diabetes also complicates their ability to heal. And that can really turn into a mess really quickly. That could have all been prevented, right? What about blood pressure? What blood pressure do we want our diabetic patients to be less than? Less than 130/80 according to the ACC AHA guidelines. And why is that? Well, that's because it will help prevent those macrovascular complications, right? It will help prevent CAD, strokes, etc. Do you have any thoughts on immunizations for these patients? Well, diabetes is a huge comorbidity to have. It affects so many different major organs, and we want to make sure that these patients have Tdap, annual flu vaccine, hepatitis B series, zoster, and pneumococcal. I mean, they really get it all. One of our biggest concerns with diabetes is their kidney function, because like we've talked about before, both diabetes and hypertension are huge risk factors for chronic kidney disease. And so that's why we start looking at kidney function labs such as BUN, creatinine, GFR, and microalbumin at least on an annual basis for diabetic patients. Now, aspirin has a question mark by it. People always seem to be confused about aspirin and whether diabetics should get it. Well, the current recommendation is that low-dose aspirin should be used in those with diabetes who are at a higher cardiovascular risk. All right, y'all, that's the highlights of diabetes. As always, happy studying. Hopefully at this point you realize that you knew a lot more about diabetes than you likely thought you did. Remember, the exam is not trying to trick you. It's testing the basics of nurse practitioner care. Please feel free to reach out to me if you're interested in the review course, and definitely be on the lookout for more free videos soon.